Thank you very much. So we are discussing impact of fluid balance. I have a few conflicts of interest, but none related to this presentation. I fully agree with previous speaker. Acute kidney injury is frequent, is associated with increased morbidity, increased mortality, increased risk of further episodes of AKI, nephronic loss, and ultimately episodes of chronic kidney disease. So definitely we might want to limit acute kidney injury or to prevent additional renal injury. It is usually believed that renal hypoperfusion is a key issue in acute kidney injury, and this is probably partly true, but not as we may think. Hemodynamic management may help to mitigate acute kidney injury, and this is probably untrue. Fluid might be good for the kidney, and this is absolutely untrue. And that oliguria should be treated, and that fluid is an appropriate option, and this is also probably a conceptual mistake. Renal hypoperfusion is a key issue in renal dysfunction. This is true. We all know that at bedside, we usually assess renal function as the glomerular filtration rate. The main driving of the glomerular filtration rate is a driving pressure within the glomerular capillary, and we know that this is finely reguled and that there is numerous factors that might decrease the glomerular capillary pressure and therefore decrease the ultrafiltration. However, believing that in our patient in the ICU, the systemic hemodynamic might be the main factor associated with AKI might be misleading. We know that at least in sepsis, both experimental model and human model demonstrate that the renal blood flow is usually increased at during sepsis, except during the very early phase. And some models even tell us that the lower the renal function, the higher the renal blood flow. This is not something that is due to the systemic hemodynamic, but this is the renal hypoperfusion is mainly due to macrocapillary dysfunction, and this is how things are believed now. We believe that there is endothelial dysfunction, macrovascular dysfunction, dysregulation of the medullary perfusion, occurrence of hématie rouleau, and all this participating to the renal hypoperfusion and being poorly accessible with fluid or vasopressors. Hemodynamic management may mitigate acute kidney injury. This might be true. There is some data suggesting that the higher the mean arterial pressure at the early phase of sepsis or septic shock, the lower the rate of acute kidney injury. But this is not a causal relationship, and probably this is also a surrogate of patient severity. And you will agree that if I'm saying that the more severe the patient, the higher the risk of acute kidney injury. This is something you all know. This is something that may not help us at bedside, and there is little data to suggest that increasing mean arterial pressure is associated with lower risk of acute kidney injury. There is a sepsis-PAM data, but this is nearly all we have. More interestingly, there is a strong dissociation between the patient that may respond to fluid challenge and patient that may have a renal response to fluid challenge. You can see here what was obtained in patient with oliguria. You have in the upside of the slide, the patient who are renal responder and non-responder. Not surprisingly, urine output increased more in patients who are renal responder to fluid challenge. But you can see that even in patients that are non-cardiac responder to fluid challenge, there is an increase in urinary output. This is absolutely separated, and the same is true when we assess renal response according to change in plasma creatinine. There is no relationship between hemodynamic response to fluid challenge and renal response to fluid challenge. Fluid is good for the kidney. This is something that is absolutely untrue. We have now a lot of experimental data suggesting that fluids, and this is true for all types of fluids, are deleterious for various organ function. We know that it may induce pulmonary edema. There is the same for cardiac function. We have very nice data in animals demonstrating that the higher the fluid overload, the lower the cardiac diastolic function. There is the same for gut, for liver, and for kidney. But please keep in mind that the kidney is an encapsulated organ, and the higher the intracapsular pressure, the lower the renal function. And all this leads to a strong association between fluid overload and risk of death. These are data from the DOREMIFA study. You can see that the probability of dying during ICU increased progressively with increasing fluid overload. And this is true for patients, whatever the renal function, patients without renal dysfunction, patients with acute kidney injury, patients requiring renal replacement therapy. The higher the fluid overload, the higher the rate of death. Patients who are surviving ICU have lower fluid overload. This is something that is demonstrated in this study and numerous studies in the literature. And the kidney is a major target for fluid overload. We know that experimental studies demonstrated that the intracapsular pressure is associated with acute kidney injury. In this study, this was not fluid overload. This was only a renal ischemia reperfusion lesion, but ischemia reperfusion increased the intracapsular pressure, squeezed the kidney, squeezed the vasculature, lead to acute kidney injury. And interestingly, in this study, when animals were exposed to capsulotomy, a simple puncture to the capsule, there was a decrease in the rate of renal dysfunction and renal dysfunction severity. Clearly, if you are using fluid in patients to prevent acute kidney injury, this will increase the interstitial pressure. This will increase the rate of acute kidney injury. And this is demonstrated for surrogate of fluid overload. But Mathieu Legrand demonstrated that if we are using central venous pressure for a surrogate of fluid overload, the higher the central venous pressure and the higher the rate of acute kidney injury. You will say that central venous pressure is probably a poor surrogate of fluid overload. I will agree with that, but there is not only the central venous pressure, there are also randomized trials. This is an RDS network study comparing two strategies of fluid management in patients with ARDS. The endpoint was not renal function, but you will see that there is a strong trend toward a higher rate of renal replacement therapy in patients with liberal strategy, with higher fluid used to manage patients. And in the same line, patients who had important peripheral edema, once again, which is a surrogate of fluid overload, but a much more interesting surrogate than central venous pressure, have higher rate of acute kidney injury, more severe acute kidney injury. Definitely, fluid overload cannot be considered as a benefit for the kidney. And this is true for every of the subgroup of patients, patient with sepsis, patient without sepsis, patient with previous chronic kidney disease, patient without, patient treated with diuretics or not. This is something that is true in every of the subgroup of the patients in this study. Last, in animals model at least, using fluid to treat sepsis-like such LPS-induced dysfunction is not associated with prevention of acute kidney injury. There is some fluid management that were found to be beneficial in these studies. Most of the studies were performed by the same group, which is the group of Can Inche, but at least using crystalloids to treat hypoperfusion of the kidney is not associated with a decreased rate of acute kidney injury or a decreased severity of renal dysfunction. This is true in most of the studies performed by this group. And this leads to the last question we might have. Should we treat oliguria and should we use fluid in this patient? Probably not, at least not for the majority of the patients. We know that oliguria is part of the ACI definition. This is true. We also know that patients who have only oliguria have a lower risk of death than patients with increased serum creatinine. We also know that the rate of patients with oliguria who subsequently developed a serum creatinine-based definition of acute kidney injury is limited. In this study, this was only 13% of the patients. Only 1 of 9 patients with oliguria will develop an acute kidney injury according to the serum creatinine definition. You can see that the positive predictive value is very poor. You will argue that probably the negative predictive value might be interesting, but this is true only according to the incidence of the acute kidney injury. The lower the incidence, the higher the negative predictive value. This is mathematics. So this is something that is well known. And more importantly, if we look at the usual cutoff, which is debatable, I agree, of 0.5 milliliter per kilogram per hour of oliguria to define oliguria, you can see that you need to have several dozens of hours to see an increased adjusted risk of mortality, and even more when it's trying to assess the need for renal replacement therapy. This is obviously a very poor marker of acute kidney injury. Probably this is a good symptom, something that tells us that we need to assess the patient condition, but not necessarily to act as physician. In a very nice Christmas BMG, there was a very nice study demonstrating that residents had a higher rate of oliguria than patients, and recalling us that oliguria is at first a preventive mechanism and not a mechanism of acute kidney injury, but a cause of acute renal success, which help us to manage volemia. This leads to my key message. What we know is clearly fluid overload is associated with organ dysfunction, AKI, and mortality. And this is something that is true in every of the studies performed to assess impact of fluid overload. Oliguria is a symptom and does not necessarily need to be treated. This uncommonly leads to increased serum creatinine, and probably a systematic reaction to oliguria might be deleterious. Acute kidney injury, at least during sepsis, septic acute kidney injury, is frequently associated with preserved renal blood flow, and probably we should forget that hypovolemia is due to microvascular hemodynamic. This is due to medullary hypoperfusion that may not be accessible to fluid challenge, and renal response to fluid challenge is absolutely dissociated from cardiac response to fluid challenge, and this is something that we might keep in mind. What we don't know how to identify renal responder to fluid, and this is something that is going to be a major issue in the forthcoming year. We don't know when or in whom we should give or avoid fluid, at least to prevent or mitigate acute kidney injury. And my conclusion is clearly fluid should not be given too much, certainly not to anyone, and probably not to treat a symptom. Thank you for your attention.